let me. So, welcome to this evening PGNR session and digital seminar organized by Dermatologists Consortium of India. And we welcome Dr. R.D. Mehta, Dr. Rajesh Dutt Mehta, who is a professor and head of dermatology at Bikaner Medical College, and he will be speaking on erythroderma simply different. So, Rajesh, a welcome bouquet, virtual bouquet for you, and a
Thank you,
turban,
sir. Thank you so
turban.
much. Always in
Rajasthani turban. And
yeah, blessings from you, sir. The bouquet is nothing but blessings from my
and and
teachers.
and and Dr. Agrawal sir, Dr. Agrawal sir will be telling you, will be speaking something good about you. Dr. Agrawal, Dr. US, Dr. Agrawal, क्या हुआ? Dr. US, Dr. US.
सर मेरी आवाज आ रही है क्या?
हाँ, आ
हाँ
गई,
सर,
आ गई, आ
आ
गई.
गई, बिल्कुल जी सर.
We are waiting for you. Kindly speak few words about Dr. Rajesh Dutt Mehta. He's
Good evening, sir. Good evening, everybody. I am pleased to introduce today Dr. Rajesh Dutt Mehta from our institute, SMS Medical College, Jaipur. And at present, he is senior professor and head of dermatology, SP Medical College and affiliated PVM group of the hospitals, Bikaner. He is a very hard-working academician who has published more than 122 papers in the indexed international and national journals, has contributed 40 chapters in postgraduate textbooks, diabetology and psychiatry, and he has got a special interest in geriatrics, allergy, immunology, STD, AIDS, oncology, and dermatology.
ये राजेश ये क्या है? कैमले वेटरनरी.
Sir, camel veterinary science. This
अच्छा,
is
कैमल वेटरनरी साइंस.
the camel milk cream, sir. We
All
have
right.
worked on that, and they have published this chapter in IGI US Publication House with the boon in disguise, the camel milk as cosmeceutical, sir.
All right.
This June only in 2020 we got it published, sir. It's a
Tell us
US IGI
tell us
publication, sir.
something about that also, please.
जी.
Sorry, I could not rather spell it out, so I will
सुनो, अरे मेरे को भी नहीं हुआ तभी तो मैंने कहा यार ये क्या लिख रखा है. मैंने कहा मैंने ये देखो तो वो क्या कैमल के बाद में. अच्छा, दूसरी बात है कि मेरे को समझ में नहीं आया. मैंने कहा यार ये क्या चीज है.
So, Dr. Mehta has won many awards. I will enumerate few. Dr. B. Govindan Nair Memorial Award Gold Medal in 2001, Best Paper Research Award, STCON National Conference of IS STD and AIDS 2009, Dr. P. A. Sanathan Memorial Award Silver Medal 2001, Dr. P. A. Sanathan Memorial Award Silver Medal 2009, Rajasthan Patrika Samman Sammelan in 2009, and Dainik Bhaskar Ek Samman Award for the Excellence in Healthcare in 2019. Besides, he has got many other achievements, but to be short, we will be very happy to listen and learn something about the erythroderma problem.
Namaste.
ये क्या किया किसी ने, वो बिगाड़ने की कोशिश कर रहे हैं कि आजकल बच्चे लोग जो है ना वो उस पर वो कर देते हैं, छोटे छोटे बच्चे जो है ना।
जी जी।
एनीवे तो वो आई जस्ट स्टार्टेड गेटिंग इट क्लियर्ड वन. So let me stop sharing this. Rajesh, you please share your screen.
Yes, sir.
Great.
Salutations to my teachers, Dr. Dinesh Mathur, Dr. U.S. Agrawal sir, and all other esteemed teachers I had been nurtured where at SMS Medical College. And very pleasant evening, ladies and gentlemen, worldwide I'll say. The talk of the day is on erythroderma. Simply difficult. Why simply? Because any person entering with this condition in dermatology premises, whether OPD or IPD, comes with its morphological diagnosis. No ifs and buts. But as a clinician, the algorithm taught to us from different textbooks, from our teachers, different research articles, is required for the basics of a subject. I do agree. It nurtures our gray matter to sharpen our intelligence. I do agree. I believe in that. I don't deny and I won't defer. Our eyes don't see what the brain doesn't know. And I keep on telling even my UG student, PG students, and my colleagues there that a dermatologist for that matter, and overall a clinician, should have microscopic vision with telescopic eyes. As our eyes don't see, I'll repeat what the brain doesn't know. But there is a wide gap between theory and practical. We have to titrate the knowledge against clinical proficiency of ours, because sometimes, never mind to be labeled as a scientific quack also, because in view of a large benefit of symptomatic relief to alleviate the suffering of a common man. So simple, the condition erythroderma, but real tough nut to break, a real uphill task to manage. What's it? If I am to define that, erythroderma is, as per definition goes, the squamation with erythematous dermatitis, which involves more than 90% or more of the body surface area. I'm audible perfectly? Some prefer to call it exfoliative dermatitis. The other synonym goes as Redman syndrome, that holds good for generalized idiopathic exfoliative dermatitis with pronounced palmoplantar keratoderma and dermatopathic lymphadenopathy. And of course, in investigation, we find raised serum IgE levels. If we go through the statistical stats available with us from different study materials, the male preponderance is there. It's as high 2 to 4 times as compared to females. So male is the sufferer, as always been. Age, not having any gender bias, ladies and gentlemen. The age sufferers, middle age onwards, its mean age turns out to be 48 to 52. Mortality is that high, looking at a dermatological condition, up to 15 to 20% in different analytical studies. Rural preponderance is there over the urban ones. Out of the list of the persons suffering from erythroderma, the condition, 50% of the cases have evident history of underlying localized disease process of dermatology. What we are supposed to do, we have to follow an algorithm, the step ladder pattern with longitudinal evaluation, which leads to precise identification in almost 1/4 of the cases. Rest quarter of the cases are idiopathic erythroderma. Why should it happen that the person suffering from a dermatological condition or otherwise would develop scale formation or desquamation? The pathogenesis revolve around There is increased number of germinative keratinocytes in persons suffering from erythroderma, which have got high mitotic rate. And when analyzed, they have got shortened transit time of cells through the epidermis. If we reassess the physiological desquamation, it is 0.3, that is 300 milligram in 24 hours, which hikes to 20 to 30 gram in 24 hours. The key and immunosenescence is being proven if we look for the etiology in geriatric and pediatric spectral ends of age cycle. The conditions from 1 to 5 ultimately tend to develop presence of substances in squames or scales which are normally retained in the skin. These are soluble proteins, amino acids, and nucleic acid. The systemic presentation of a case of acute erythroderma. The acute erythroderma will have clinically high cutaneous perfusion that would include temperature dysregulation, hypothermia can be observed, desquamation, the basic component of erythroderma. The person will have tachycardia, and ultimately there would be high output cardiac failure. All these conditions termed under category 1 would lead to raised BMR, which is compensatory to high heat dissipation. And there would be higher transpiration from skin, and that higher transpiration would land with increased dehydration. To continue that, the conditions just described from category A to D leads to negative nitrogen balance that will cause in acute cases peripheral edema, hypoalbuminemia, loss of fluid and electrolyte, and that would conclude as condition with dehydration because of, again, I've just mentioned, increased transpiration. When the condition from acute passages to chronic condition, then what we'll find? The person will present to us with cachexia, that's resultant of compensatory hypermetabolism. Patient may develop iron deficiency anemia. Peripheral lymphadenopathy would be there. The person may have clinical as well as sonographic finding of hepatomegaly, and we may even have ocular complications in chronic cases of erythroderma in form of ectropion and purulent conjunctivitis too. What are the culprit conditions? That is how to classify as far as etiology is concerned. I'll be talking something very common because otherwise there are long lists. That means every dermatological condition more or less can take a person from simplest of skin diseases to erythroderma. Out of the list, I've tried to classify depending upon the age groups. In adults, the very common underlying diseases, the group is atopic dermatitis and various kinds of eczemas. 25% of the cases of erythroderma will have a predecessor as psoriasis. Lymphoma leukemias, including CTCL Sézary syndrome, can be a cause, an etiological factor in 15% of the cases. ACDR, of which my colleague Dr. Lalit Gupta is expert of, would definitely agree. The different studies show that 10% of people having ACDR would present as a case of acute erythroderma. And of course, idiopathic erythroderma, if I'm permitted to say off the record, literally, the clinicians are unable to define the cause, to pin down, to nail down the etiological factor. The condition of the patient is pathetic, and of course, if permitted to say so with permission of the chair, the clinician turns out to be is there in 8% of the cases. Next in the list are the less common of the conditions, like CTCL can be grouped under lymphomas and leukemias too. It has got two variants, Sézary syndrome and erythrodermic form of mycosis fungoides. PRP, very rarely I've seen a case of PRP in adulthood developing erythroderma, but theoretically, yes, we should know. Context and stasis eczema, The rural population mainly suffers from ABCD, the airborne contact dermatitis, Parthenium being the main culprit, paraneoplastic erythroderma, different vesiculobullous disorders, and out of the list, it is pemphigus foliaceus, which tops the list, followed by bullous pemphigoid and paraneoplastic pemphigus. Inherited ichthyosis can also be there. Adults, very rare conditions which may cause erythroderma are lichen planus, graft versus host disease, crusted scabies can even cause erythroderma, but it does happen. We have come across very few cases, but still we have to keep it in mind in Indian pretext. Mixed connective tissue disorders like LE and other conditions, chronic actinic dermatitis, something overlapping with ABCD, the airborne contact dermatitis, and of course, very rare condition, theoretically important, papuloerythroderma Fuji. If we just shift from adult to pediatric age group, the common underlying diseases which cause erythroderma, the list is again being topped by atopic dermatitis, seborrheic dermatitis, psoriasis, ACDRs, and of course, 2S2S or 4S that stands for staphylococcal scalded skin syndrome, neonatal toxic shock syndrome, and congenital cutaneous candidiasis. And one of the causes for erythroderma in pediatric age group. The common conditions which we come across not very frequently, but there are definitely cases of inherited ichthyosis, which does have all the variants. That's epidermolytic ichthyosis as per newer nomenclature, the bullous variant, the congenital ichthyosiform erythroderma, the non-bullous variant, the older nomenclature, Netherton syndrome, Conardi, Hunerman-Happel syndrome, and immunodeficiency in form of Omen syndrome, Viscott-Eldridge syndrome to complete the list. In pituitary age group, the very less common diseases, and Indian pretext in our Rajasthan state also, nutritional dermatitis, very prevalent. Kwashiorkor is one of the cause. PRP, graft versus host disease, diffuse cutaneous mastocytosis, and KID syndrome are there, which can be put under the category of etiological conditions, which may cause a pediatric age patient to land with erythroderma. Now, as I just said, I have to go through the list because the clinical signs can be only visualized when our brain knows about that. And then again, we can categorize them depending upon erythroderma. If it's a primary type, we'll have truncal erythema for days to week, followed by desquamation or scaling. And if it is secondary in nature, there would be generalization of preceding localized skin disease. So the person would have a definite history of preceding localized dermatopathology. In acute stage, if we go by the scale of the person presenting to us in our OPD or IPD setup, if the condition is very acute, the scales would be large and crusted. Very fine tips, but if we can just remember, we keep on practicing, we'll be in position to nail down the diagnosis. In chronic stage, the squames turn small and dry. Etiology was atopic dermatitis as well as dermatophytosis. The new epidemic as far as dermatology is concerned, the scales will be very fine. If we find the scales are briny, the condition behind the erythroderma would be seborrheic dermatitis. And in pemphigus foliaceus, the commonest of the autoimmune bullous disorder group of the diseases, the scales would be crusted one. Then to the symptoms with what the person present to us. Itching, the foremost symptom in patients' diary. Pruritus would be there in 90% of the cases, and it would be maximized in cases who had dermatitis in past, or it would be very pronounced if the person had Sézary syndrome as etiological cause of erythroderma. Lichenification can be observed in 33% of the cases. Of course, the case should be chronic one. Dyspigmentation would be again a symbol of chronicity of the disease. Palmoplantar keratoderma, very common with lymphoma leukemia type, and it would be there in 30% of the cases. The nail changes, the onychal changes, and it would be in form of shiny nails because of constant rubbing or scratching of the skin. And diffuse non-scarring alopecia can be present in 20% of the cases who are suffering from erythroderma. Oh, I know with this much of theory, anybody can have yawn and sleepy heads, and we are inching towards our dinner time also. Let me have a sip of glass of water to just hydrate my throat also. The person who is coming to OPD or IPD setup, clinical clues we can have in form of sparing of central face. Patient of erythroderma, but central face is spared. The first tip that goes to my mind would be the person might have had psoriasis. And if we examine properly from top to bottom, we can find pre-existing or remnant psoriatic plaques. I have got a picture gallery of mine that I'll show later on. And if we look at the nail, the onychal changes, we may have different findings in form of pits, oil drop sign, and of course, in certain cases, we may have onycholysis also. The histopathology with hematoxylin eosin staining, good enough with high power. What we find, we can have the biopsy. Person would have classical findings of parakeratosis, reduced or absent stratum granulosum, epidermal hyperplasia with bottleneck reteridges would be the finding, and blood vessels would be tortuous, and neutrophil would be observed in epidermis. Sorry for the technical. Oh, then the supportive evidence would be in form of the person would have either himself or herself suffering from psoriasis in past, or there would be definite family history of psoriasis to support our clinical diagnosis as far as etiology is concerned. And most of the people who had psoriasis in past, they will give history of drug withdrawal, which was maintaining their psoriasis in stable form. That can be steroids by quacks or otherwise by my clinician friends, methotrexate, even cyclosporine and biologics, if withdrawn or tapered, can lead to psoriatic erythroderma. And the person can be for other ailments beyond lithium, beta blockers, antimalarials, and interferons too. Atopic dermatitis. Again, the presenting clinical clues we can have, the person would have pre-existing flexural eczema. The person would come with intense itching. And of course, if it's chronic, then we can observe lichenification also, and that too involving the eyelids. The histopathology, HNE staining with 40X, that's parakeratosis, variable degree of acanthosis, spongiosis would be there, dermal edema, and eosinophilia if our eyes are trained enough to see the eosinophils. And infiltrate would be in form of lymphohistiocytic with exocytosis of lymphocytes. The support we can have to our two existing clues would be there would be triad of atopic clinically that can be true personally as well as family wise. The person will have history of bronchial asthma, himself, first self, or in the family, allergic rhinitis, and atopic dermatitis, completing the triad of atopy. Investigative battery, raised Ig level in serum. Eosinophilia will be there in CBC, and ophthalmic corroborative finding can be there in form of cataract and keratoconus also. ACDR, it not only involves, it is not only the cause, the allopathic medicine, and most of other our friendly holistic medicine approach people from different indigenous medical pathies, they say that their drugs won't have any side effects. It doesn't suit to my gray matter. Why? If something is having effect, definitely it ought to have some side effects. And even some of the philosophy of different pathies says अंग्रेजी दवाइयां बीमारी को दबाती हैं हम बाहर निकालते हैं. And that passage of बाहर निकालना may land a person with I'll say erythroderma. And the person will have drug ingestion history. And if you look properly, the dependent areas of body will show purpuric rash that can be in form of morbilliform, scarlatiform, exantheme precedence would be there. And there is a long list. I've taken out of the scores of drugs. Practically speaking, any drug can cause erythroderma, can cause adverse cutaneous drug reaction. And Dr. Lalit Gupta, if he's just hearing me, would just bail me out. But I've just chosen the commonest drugs, the beta-lactam antibiotics, carbamazepine, phenytoins, I've got a case, sulfur drugs, gold, the dermatological drugs, very common in use, DDS, the dapsone, talk of the town, talk of the era, talk of the pandemic, HCQ, methotrexate, INH, retinoids, lithium, minocycline, clofazimine, terbinafine, all mostly from the kitty of dermatologists, that we should even be aware own self that these common drugs we are using day in and day out can lead to erythroderma. It is being supported with, just a moment, there is some clinical clues of next condition has come. The support is by that the person would come out with negative history of skin diseases. That means if we evaluate the history of that person, he or she will come out that I have never suffered from any disease of dermatology. Only the first presenting disease would be erythroderma, that too be just caused by a drug. Most of the time it is very acute in onset. And the good point about the ACDR induced erythroderma, it resolves in 2 to 6 weeks after withdrawal of the drug. Then comes the idiopathic erythroderma. Few says it is 8%, others says it is 25%, and the number, statistical number, can vary from study to study. But most of the time it happens in very old persons, the geriatric population. It is recurrent and chronic in nature. The person suffers from intractable itching, not able to hold his or her hands. With chronicity, there would be palmoplantar keratoderma. And if we are keen examiner of a person in toto, the person may have dermatopathic lymphadenitis also. Histopathological support is in form of acute stage. We can have parakeratosis, spongiosis, lymphohistiocytic infiltrate. The chronic stage would have hyperkeratosis, psoriasiform acanthosis, and expanded dermal papilla. I know it's difficult to remember, and just it is all just getting into an admixture of different conditions having almost more or less similar features. But as a student of dermatology, we should try to cram these, learn this, and bring it into our practice. The support for idiopathic erythroderma is there is rare drug ingestion. Longitudinal evaluation is definitely helping us out to reach the diagnosis of idiopathic erythroderma. And we require serial cutaneous biopsy to rule out CTCL. Next condition is CTCL. Not very common, but yes, it is there. The person entering the OPD will have strong purplish or red shade labeled as melanoerythroderma. Mind it, it is strong purplish tinge or red shade of the erythema. Leonine face is what commonly thought would be marker of lepromatous leprosy. Because of infiltration, edema of face in CTCL2 will have leonine faces too. The person will have again severe itching with lichenification and prurigo-like lesions. Palmoplantar keratoderma would be there, which would be associated with fissuring and pain. The person would have alopecia and lymphadenopathy. If we are a keen observer, we have lymph nodes. The histopathological evidence which supports we require serial skin biopsies to reach the diagnosis of CTCL. That means most of the time it's inconclusive. But if our eyes are trained, we have cerebriform pleomorphic lymphocytes. We require a real training to just identify these pleomorphic lymphocytes, which are cerebriform. Clustered atypical cells in epidermis is uncommon, and of course, band-like infiltrate is there. The support, it is again very difficult because CTCL-induced erythroderma is a great mimicker of various kinds of erythrodermas. But if we can observe peripheral blood in our investigative battery, it will show if we have got marker facility in higher institutes, CD4 positive lymphocytosis. There would be an elevated ratio of CD4 versus CD8 going as high as 10:1. Similar clonal T cells in skin, biopsies, lymph nodes, and blood can be observed. And Sézary cells number goes more than 1,000 per mm cube in blood. Then coming to the kids, the pediatric age group. The commonest of the condition causing erythroderma in pediatric age group is epidermolytic ichthyosis. Clinically, the parents would give history of superficial vesiculobullous lesion and erosions during the initial days of the life, if we go by the neonatal history. And on examination, clinical clue would be in form of flexural corrugated lichenification, which is there in the later part. The histopathological indicator would be not very specific. Epidermolytic hyperkeratosis would be there, and very high profile academics. If we have got genetic engineering, molecular labs available with our centers, mutations in KRT1 and KRT10 can be just a real supportive index. The other variant, the non-bullous type of inherited ichthyosis, the congenital ichthyosiform erythroderma, the newer nomenclature, the parents would say that baby was a collodion baby with generalized scaling. We'll have cicatricial alopecia. If we examine the nail, there would be nail dystrophy. In very young age, the child would have palmoplantar erythroderma, and even we can observe ectropion if we are trained to observe that. Histopathological indicators are not very conclusive, but of course, the molecular genetic investigative tools would make us more wiser. That is, we can observe mutations, TGM, LOX3, LOX12B, really difficult to remember, but I have to just enumerate those. Again, a double click, it is just flew like anything. Sorry for the technical error. And Netherton syndrome, the next condition, the person will have history from parents, atopic like dermatitis with food allergies of different kinds. The eyebrows, lashes, and scalp would have bamboo hairs. Mind it, bamboo hairs in eyebrows and lashes also. And parents would give history of failure to thrive. Histopathology is not very conclusive, but the investigation tools show that the person will have raised serum Ig levels, and again, mutation in SPINK5 and LECTR. Next. 2S, 4S, staphylococcal skeletons syndrome. History, definitely a focus of staphylococcus infection in skin. What we observe as clinician, accentuated skin folds. There would be history by parents of superficial bully eruption followed by scaling. On touching, there would be tender erythema, and radiating perioral scales and crust would be there. If we can perform a biopsy in small kid, we can have a subcorneal split in HN staining. The supportive evidence, again by the lab, would be Staphylococcus aureus culture being positive, and if we can find the toxins, exfoliative toxins, ETA and ETB. Again, a big dilemma. We reach the diagnosis, but now how to treat? Now this is something like solving the maze. And I just suggest, submit humbly, that we have to follow a managing tripod that includes clinical evidence with which the patient or the attendants enter the skin OPD or IPD, confirmed with histopathological support, and of course, we have to provide treatment to the patient. Then clinical longitudinal evaluation does have two components: history, just narrated, and specificity of the clues would help us out to reach the diagnosis as far as etiology of erythroderma is concerned. Histopathological support is required, which happens to backbone of our etiological diagnosis. Now, dividing the treatment into phases. One is cutaneous component, and more important than is journal. Journal treatment requires high dependency unit. It's not simply the MCI regulation, it is even warranted with every dermatological IPD setup. I think in first of the webinars I've attended, my esteemed teacher, Dr. U.S. Agrawal, just underlined that they have just got it when he was principal and HOD of skin at SMS Medical College, Jaipur. Even we humbly say that we have developed that SDU that will take care of different cases of erythroderma and the cases landing with dermatological emergencies or even in skin failure. So SDU turns where the PG students, the clinicians should be trained with advanced life support system and basic life support system, that we should be trained not only for MCA curriculum but otherwise to be a confident clinician with different postings in medical ICUs and critical emergency units. And cutaneous treatment, of course, does have two components of topical therapy and systemic therapy. Hospitalization in SDU, if required, it does have A, B, C, D of management. Mnemonics goes as: we have to maintain breathing by maintenance of airway. We have to maintain the circulation to prevent the high cardiac output failure. And of course, the dermatological deformity is to be prevented, which can be in form of persistent lichenification, hypopigmentation, depigmentation, and hyperpigmentation. That is to improve the dermatological quality of life of a sufferer from erythroderma. And not only the patient, but the caretakers also require emotional assurance that nothing is going to happen. If we are trained enough, we can ensure our patients and attendants with erythroderma. With God's grace, the person would come out with this difficult span. In general measures, nutritional importance or assistance is of prime importance. We have not only to take care of the daily requirement, but this is also desired for sepsis prevention. For that, the basic thing is protein. If the person is unable to take by mouth, he should be provided with human albumin 1 milligram per kg percent of body surface area involved. Second component is fluid electrolyte balance, which is 0.7 ml per kg of body surface area. It is of much more importance for the spectral ends, that's for the pediatric age group patients as well as geriatric age group patients. And if you have got HDU, that's high dependency unit in our IPD setup, hypothermia can be prevented if we can afford infrared lamp with temperature managed between 30 to 32 degrees Celsius. And of course, this superadded infection, whether bacterial, fungal, anaerobe, or viral, are to be dealt with. Then hardcore facts that one should be remembering on tips. Easy, simplified way, very first day of admission, the fluid should be given 1.5 to 2 liters. And the calories should be, again, 1500 to 2000 calories per day. And the choices can be for calorie, human albumin, fresh frozen plasma, and normal saline, to be followed by increase of 500 calories per day depending upon the condition of the patient. And protein should be as good as 2 to 3 gram per kg per day, whether given orally or whether through human albumin. And the dietary components of such requirements can be in form of milk, fruit juice, honey, and of course, to take care of the decreased amount of potassium, it is KCl syrup, which is warranted by some of the patients. Then symptomatic solutions. Pruritus, really notorious, requires sedating oral antihistamines. Rapid clearance. This is walking on a sharp-edged sword, that is systemic steroids. Drug of choice for idiopathic or ACDR induced erythroderma, but so many buts are there. Prednisone or prednisolone initially should be in dose of 1 to 2 milligram per kg per day, and maintenance dose with tapering can be 0.5 mg per kg per day. But there's again a chance of rebound phenomenon 1 and superadded infection of various kinds. So we have to be very choosy, very methodical in tapering the dose of steroids. And infections, of course, are to be taken for symptomatic solution with antibiotics, antifungals, antivirals, and taking care of the anaerobes also. Cutaneous therapy. Topical therapy includes topical steroids. The ideal one is low potency, usually steroids. High potency for chronic lichenified lesions on skin. We should prefer open wet dressing with bland emollients. And there were studies from Indian different institutes from South India and from even AIMS where they've used banana leaves in cases of erythroderma with skin failure-like conditions. And topical antibiotics, if required, we can add to our kitty. Then there are certain teasing hurdles. I've just mentioned systemic steroids. Do's, ifs, buts, don'ts. But again, it requires an intelligent titrated tapering schedule to prevent rebound phenomenon as well as to take care of the superadded infection. Because for early recovery, earlier the better, earliest the best, to tackle the life-threatening condition, that is if the person lands into a case turning into mortality because of erythroderma. So we have to just start very promptly steroids, but judicious tapering is required, not to put the person on prolonged steroids. Sorry. Topical therapy should avoid coal tar, salicylic acids, and few of the authors say even lactic acids is to be avoided. Others prefer it. Different viewpoints. Then targeting a specific conditions. For psoriasis, my experience is, and most of my senior colleagues would agree, methotrexate is drug of choice. Apremilast, a new drug. Cyclosporins does a very good result. Acitrin, and of course biologics to be balanced with side effects which are probable. But steroid, again in psoriasis, is very tricky. Tapering is to be judicious, otherwise we may have even pustular flare. Then for ACDRs, the story begins with withdrawal of probable drugs, stoppage of non-essential drug in polypharmacy, and the story continues or ends with systemic prednisolone, and sometimes if the situation is critical, you may require IVIG also. Topical therapy in idiopathic erythroderma is low potency steroids. Systemic therapy, of course, prednisone or prednisolone in 1 to 2 mg per kg per day. Steroid sparing agents can be in various forms, that can be in form of retinoids, cyclosporins, methotrexate, azathioprine, and few of the conditions even demand mycophenolate mofetil also. Going through the Guillory pictorial, a brain teaser for my budding dermatologist PG friends. Yes, you are absolutely right. It's a case of 4S or 2S2S. To be more just specific, is Staphylococcus scalded skin syndrome. The baby just ultimately had erythroderma. Very theoretical. If you can make out orange red hue in the left end of the picture and the right side showing the islands of sparing, it is a case who had PRP. I've taken from a picture atlas. I didn't have any case of mine showing PRP going into erythroderma. Yes, again, use your memories, the youngsters, the PG students. You can have certain blisters also, then lining with erythroderma. It's a case of pemphigus foliaceus developing erythroderma, impending erythroderma. The clue is very much there because the person was a very regular visitor of our OPD. He had, sorry, he had chronic erythematous plaque type of psoriasis, different therapies. Patient got relieved. All of a sudden, maybe he just landed with some quacks therapy, put him on steroid, started developing larger lesions, and ultimately landed with erythroderma. The steroid story of quacks very prevalent in this part of India. Hmm, really pity state of affairs. You can see a baby girl really in agony, an ectropion there. I think you should come out with a diagnosis of atopic dermatitis. With cyclosporin therapy, the problem with patient was that she used to respond with oral steroids, and when started tapering with relief, again there would be a rebound flare, superadded infections. Just I had to ask the parents to go ahead for a costlier version that was of cyclosporine, and the baby is, you can very well see, the ectropion component is even improving, and the agony clinically has gone down. Again, a case of ACDR, and the person was epileptic, had the history of taking phenytoin for seizures for last 6 months, and all of a sudden, almost 7 days back, he developed erythroderma because of phenytoin. The drug was to be withdrawn, and he has started improving the signs of erythroderma, and he is with our pediatrician friends, and we are taking care of the dermatological component. ABCD, airborne contact dermatitis. Very well evident in this picture, the tongue getting involved, seasonal for last 3 years, and the periorbital area makes a diagnostic clue evident to every clinician, and we should learn to that. The limb getting involved. This is his picture with erythroderma for last 3 years off and on, and he has permitted me to put his photograph. He just talked to me 3 days back on video dermatology. He said, "Sir, 3 years back I used to look like that, and I do have a sweet desire to have my skin back like I used to look 3 years back, and I'm trying my level best. And within 3 days, the itching has gone, the scales have gone, and he has been put on steroid in the initial phase. And then we'll try to just convince that person, if possible, he can switch over from farming, that is his profession, to some other profession, or he can just manage those." The carry home message of the day. First, I'll talk of Corona. Dinesh Mathur sir was just telling that next PGNR would be on Corona and dermatologists and different conditions. I'll say to every colleague of mine, every fraternity friend, stay masked and stay safe. But better carry home message going through erythroderma, the dermatology practice. And I can't hold myself, if sir permits me, to go ahead with the Hindi couplet by Harivansh Rai Bachchan. I think the philosophy is required with this much of heavy talk of theory and practical tips. I'll quote Harivansh Rai Bachchan Sahab. तू ना थकेगा कभी, तू ना थकेगा कभी, तू ना थमेगा कभी, तू ना थकेगा कभी, तू ना थमेगा कभी, तू ना मुड़ेगा कभी. कर शपथ, कर शपथ, कर शपथ. Agnipath, Agnipath, Agnipath. That is how the life goes. We have to have our morals very high. Thanks a lot, ladies and gentlemen. Thank you very much. Thank you very much.
Thank you very much. Thanks a lot, Rajesh. It was indeed a pleasure listening you. And shall I stop sharing your this thing?
Yes,
And
please, sir.
Dr. Lalit is here. And Dr. Lalit, will you please present
Yes, sir.
a virtual bouquet to
Yes.
a virtual memento and this thing to.
Oh, it's my indeed a pleasure to present this wonderful memento to my dear friend Dr. Mehta. Unfortunately, I joined 5 minutes late, but I missed a little part of it. But whatever I heard from him, it was excellent as usual. And with he has a knack of finishing his talks with some couplets, and that's what he did today also, and did not fail to amuse us with that.
After this, we are going to hear the Harivansh Rai Bachchan's son, Amitabh Bachchan's program. That
Right.
KBC.
So Dr. Mehta, it was indeed excellent hear from you your views on erythroderma, and kindly accept the memento from the team, and it's our privilege and honor to present you this.
Lalit, can you please take up the questions also in the chat box?
Yes, sir. There are a few questions from the audience, and there have been some uh, appreciations for you. One has asked about the cause of melanoerythroderma in CTCL associated erythroderma. Can you shed some light on that?
It was probably
Yes.
Komal. Is it Komal Gupta?
No, it is Praveen's. No, yeah, Komal.
All right.
So melanoerythroderma is diagnostic clue, and most of the time this is the incontinentia pigmenti, which is the uh, outcome of the degeneration, and that too with the presence of cribriform lymphocytes in abundance. This is very cell that may just put, I'll say, the light physics comes in action, and because of those abundance of the rule of thumb as far as physics is concerned, the deflection and refraction and so many things around, and the erythema turns into purple red hue rather than simply red erythema. To best of my knowledge, what I can
So
do. Dr. Lalit, if you can share
that
something.
dense infiltrate of lymphocytes which are basophilic
Yeah,
may impart this bluish hue to the skin, purplish hue.
because of, yes, of course, the increased amount of that,
Dr.
and that
Praveen,
to a particular.
Dr. Praveen wants to ask, what is your opinion on IVIG in erythroderma? Have you used it?
Yes, I've used it, and for particularly critical cases, because it is not very easy for a common man to just purchase it. And we have got government supply now set up, and the people who are very critical, and they just showed marvelous response within a day or two with starting of uh, IVIG. Very good results, but it is the matter of the who can afford and who cannot afford that.
Any specific type in which you recommend IVIG or idiopathic form?
It is basically the systemic component with which
Okay.
the person is just having all these components of hypothermia and high output cardiac failure is there, and of course peripheral edema is there. So it is more of systemic manifestation than dermatological manifestation, and we can just use, particularly in case of idiopathic erythroderma, we are not able to nail down the cause. I think IVIG can be the answer as far as to alleviate the suffering of the person.
But
Dr.
the problem with IVIG
Why-
could be that you would be giving a very high fluid load to the patient who already has the high output, circulatory.
I do agree, Dr. Lalit, but it is to be just monitored, and that's why I said the advanced life support system is to be just practiced by every dermatologist for that matter, so that even we don't get tachycardia or tachypnea, just seeing a case of erythroderma or the patient landing with skin failure. So how to use IVIG, what should be the amount? It is just to be learned with practice in, just I'll say, in association with our pediatrician friends in particular and physicians also.
Dr. Niranjan Nagpur sir wanted to. Yes.
Dr. Rajesh Mehta is a very excellent lecture. It's a very good revision for all the practicing dermatologists and for PG. And only thing is that, the incidence of erythroderma due to atopic and eczema, don't it is little on the higher side? Because usually you see more
Yes,
of an idiopathic.
I do agree, sir. That was, I've just tried to compile various studies. In our day-to-day practice, is what you have just said is absolutely right. Very rarely we are able to reach the diagnosis, but different authentic international national studies put it as 25%, few say 8%. But to me, most of the cases are idiopathic where we are not able to reach the etiological cause for erythroderma. I definitely agree with you, sir.
The idiopathic and next comes to the psoriasis, as compared to atopic, because atopic as such
Agreed,
is
sir.
common in India.
Agreed. Agreed, sir.
I can see Dr. B.V. Mahajan also, but he has not opened his video here. Dr. Mahajan, Dr. Mahajan, Dr. Mahajan is not speaking. Dr. Dora R.N. Datta is here. Welcome,
Yes,
sir.
Sir, very
हाँ
good
I'm
evening,
डॉक्टर
there.
sir.
बी माया हाँ
Very
आ
good
गए
evening,
ना आ
sir.
गए क्या बात करी सर
हाँ,
क्या बात है बहुत दिनों बाद मुलाकात हुई है
अरे बीच में बहुत मीटिंग वगैरह इधर रहता है उसके लिए ज्वाइन नहीं कर पाता.
और हम डॉक्टर महाजन महाजन भी आ गए डॉक्टर महाजन ने भी अपनी खिड़की खोल ली
खोल ली सर खोल ली पहले ही खोल ली
Sir, very good evening, sir. Very good
वेरी
evening, sir.
वेरी गुड
सर
इवनिंग
वेरी एक्सीलेंट टॉक
Dr. Mehta, your was an excellent presentation. I
Sir, it
liked
is
it very
all
much.
my seniors who have blessed me. I've tried to just compile the knowledge from different books and research articles. It is nothing from my end. I was
Doesn't
just,
matter, but it was appreciative. We learned. That is the thing.
that's so great of you. So nice of you for such kind words, sir. I'm humbled, sir. Humbled, sir, Dr. Datta, sir.
all right all right
So
any other
there are,
any other
yeah,
question comments
yeah, there are a few more questions in the
sure
chat box.
sure
Some Dr. Shweta Rathi. I think it must be Sanjay Rathi. Is it Sanjay Rathi? So he
No,
wants to know, Shweta Rathi, how long to give cyclosporin in atopic dermatitis?
Sir, in recalcitrant cases, I've used in few cases, and most of the time, the average duration, it is nothing like a course of cyclosporine, it ranged from 3 to 6 months.
Yeah, it's a long.
Long duration. It's not a overnight magic at all.
What was the diagnosis in a bald child that you showed? Someone wants to ask. Komal wants to ask.
It was a chronic case of atopic dermatitis. She was
Okay, atopic
atopic, and was there with so much so itching, and
Okay.
only steroid respondent. Being a female kid, I had to just keep on tapering because she being female. Otherwise, also,
Yeah.
and superadded bacterial and fungal infections are very common. So she responded well only to cyclosporin, and within a month, she had a dramatic response.
I think it's a game changer actually. Yeah.
Yes, yes. Do
Dr.
agree.
Rajesh Rajgopalan wants to ask the blind antibiotic of choice of in erythroderma, waiting blood cultures. So, do you recommend any specific antibiotic in
So
patients?
we have to go for the safer thing, and I think Dr. Lalit would be in a better position to answer this question because we in our practice we prefer to give linezolid because it is supposed to have minimal ACDRs.
Yeah.
Anything can cause ACDR to anybody in any durations gap, but linezolid
is
in
it so
my practice,
linezolid I didn't have that impression I do not know can somebody come
sir, it is again availability of the drug and the patient's affordability. It's not very cheap drug, but if somebody can afford till the culture comes, we can use that. In our hospital practice in government supply, we have to just stick to ceftriaxone with again a chance of cephalosporins being again culprit for ACDR, but that's available for everybody in government supply setup. But if somebody can have linezolid, will have less chance, I'll say, to develop ACDR, further aggravating erythroderma.
Lincosamide is another drug which can be used. It has got a very good effect in
Do
staph
agree. I do.
and the anaerobes. So,
Yeah,
it is
both
not
are
all that
covered.
costly drug actually.
Yeah, do agree, sir. Do agree, sir.
IV human albumin is costly when you give amino acid infusion instead
Dr.
of
Raj,
IV IG. You give amino acid
I don't
infusions.
have any practical experience and
Yes.
then don't have any supportive evidence in case of IV human albumin being replaced by the amino acids. but I'll have to talk to my physician and pediatrician friends. Can it be a good alternative to albumin? Should be. Theoretically speaking, should be.
If you have an evidence of hypoalbuminemia, yes. If you have an evidence of hypoalbuminemia, then I think you can infuse the IV albumin. Otherwise, I don't think there is a direct role in the erythroderma per se.
So it is just for
It
the
can take care of
maintenance of
complications.
the nutritional
Yeah.
assistance is provided if somebody is not able to take by mouth, and
Yeah.
even it
Yes.
prevents the superadded bacterial infection, just boosting the immunity through protein being in bolus form. And again, the question of affordability of a common man.
Chalo, Dinesh, take care of.
Well,
Okay.
sir, thank you very
Thank you,
much.
sir.
Thanks a lot.
Thank you,
Thanks,
Dr.
Rajesh.
Thank you.
It was a very nice thing. And see you on Tuesday on Corona update.
Yeah.
Right, sir.
And a
Pleasure meeting
Corona
everybody.
quarantine special. Okay, bye bye. Good night. Have a nice.
Thank you.
Good
Thank you, sir.
night,
Good night, sir.
everyone. Good night.